Test is now starting. All attendees are in listen-only mode.
I put 2 on.
That's good.
So it's 8 from 8 to 10.
Okay, you can stop.
Hello, welcome to the Global Tracheostomy Collaborative webinar series. Today's webinar is Thriving with a Tracheostomy in the Community. We have over 200 people registered today, and we actually have another 200 who will join via the link that's recorded. That's just excellent. Thank you to all of you for participating, for joining, and contributing to the really exciting global tracheostomy community. You can tell I'm at work. I'm Tanis Cameron, the manager of the Tracheostomy Review and Management Service, TRAMS, at Austin Health. I'm also a speech pathologist on the services you're going to hear about today. This presentation is jointly presented by the Austin Hospital and also the Royal Children's Hospital in Melbourne, Australia. Melbourne is a vibrant city with 5 million people, and we like to boast that we have been awarded the most livable city in the world for several years in a row. That's pretty cool. Austin Health is 900 beds. We are a large tertiary care facility and operate across 3 campuses. We also have some statewide services, the Victorian Respiratory Support Service and the Victorian Spinal Cord Injury Service, which gives you an idea of our case mix. Austin is very pleased to be a founding member hospital and a lead site for Australasia for the Global Tracheostomy Collaborative. Our title today, Thriving in the Community with a Tracheostomy, is a decidedly positive statement, and that's our intention. We wanted to reflect that it's very possible with support and with strong systems in place for our patients to feel safe, supported, and confident in the community. However, we cannot forget that the literature points to high risk being associated with tracheostomy care. Certainly in the hospital setting, and as you move into the community setting, those risks increase. So universally, it's a very important topic for us to address, and that's why we're pleased to see such a good attendance today. You're going to hear from specialist teams at three different specialist teams in Australia, and they are highly integrated and specialists with high structure sorts of teams. We know from communicating and from taking communication from you that many of you do not have the luxury of being associated with a team that can easily place a patient in the community. Certainly in Australia, there are a lot of tracheostomy teams in acute settings, but not that many coordinating outpatient care. So I hope that wherever you are in that continuum in terms of your own personal setting and the model you work under, that you will hear some new and informative information, and importantly that you will learn and feel inspired to take back some of the information shared today to your own clinical setting when you're striving to find solutions to your problems. This is our disclosure slide, and I would like to comment that all images shown in this presentation have been obtained with full consent from patients and families. We have no other disclosures. You're going to hear today outline from expert specialist teams for pediatric and adult. We're going to talk about patient participation, which is extremely key and front and center. We're going to review education and training programs. We're going to talk about putting tracheostomy tubes in what setting, and finding the right fit for tracheostomy tubes. We are going to be talking about participation from the audience, and we have a polling situation that you're going to hear about. A question will come up periodically throughout this talk, and we're going to ask you as an audience to select the correct answer. We couldn't possibly go over all topics today, but we would encourage you to look at our TRAMS resources and the other website resources that are available for full details. Our community programs are completely online. The speakers today are Dr. Mark Howard, who is a respiratory and sleep physician. He's also the director of the Respiratory Support Service in Victoria. We have Christy McMurray, who is the TRAMS clinical nurse consultant extraordinaire. And I would like to comment and pause for a moment to thank both Haley Rayburn from the GTC and Christy for their extraordinarily extensive and excellent work in coordinating this webinar today. You'll also hear from Gavin Fay, who is a clinical nurse consultant with both of our teams, and Carolyn Chow, who is the senior physiotherapist with our teams. Carolyn provides many, not all, but certainly similar services to what the respiratory therapists do in the United States and around the world. We will also hear from Dr. Haitham Kaba, who is an ENT surgeon at the Royal Children's, and Sue Ellen Jones, who is the respiratory consultant there. It's my pleasure to introduce our first speaker, Dr. Mark Howard.
Good morning or good afternoon. I'm going to give you a brief overview of our services that we have at the Austin. We have two multidisciplinary teams that care for people both in the acute setting in the hospital, but in particular in the community, the focus for today. And maybe just pause to think about how those teams have developed. So we have staff ranging from medical teams, from respiratory, ENT, and intensive care backgrounds, broad range of allied health staff, including physiotherapists, occupational therapists, and speech therapists, and an expert nursing team. And that's really developed over a prolonged period of time by having people work across a range of services in the acute setting, on acute wards, moving to working with patients in the community with and without ventilation, and that's allowed the development of that expertise. On the pictures before, you've got a good example of some of the people involved and some of them speaking today. Initially, to focus on the TRAMS team, the Tracheostomy Review and Management Service, which started as an inpatient acute care service to assist with looking after patients within the acute hospital, assisting with training of staff across wards, so that where the wards where patients were being cared for, they had the right knowledge and expertise to care for tracheostomy patients, the ability to be able to troubleshoot acute problems, and they've developed policies which are used across the hospital in the acute setting, but also in the community setting to help care for our patients. And so that has then evolved into a team that now also cares for patients in the community setting with long-term tracheostomies, with education of family and carers that are kept looking after them, ensuring that tracheostomy tube choice and placements are made appropriately. Some of that is done out in the community, and some of that's by bringing patients back into hospital and by working with service providers in the community. We also have a related team which cares for patients on long-term home ventilation across Victoria. And a small proportion of those are patients on invasive ventilation with tracheostomies. So 1,000 patients overall, but about 30 or 40 at any time, usually who have invasive ventilation via tracheostomy. And this is a complex slide, but to give you some idea about this service, we have a care service, the hub of it, if you like, based here at the Austin, where we bring people in to set them up on ventilation, initially decide on settings, do education and training of carers and family. But across Victoria, we have clinics at a range of sites. I was looking up the size of Victoria compared to some states in the US by way of comparison. And I think Victoria is about the size of Wyoming, but with a population of Massachusetts, so a reasonable size to cover. And then we work closely with other units. We wean patients from ventilation in hospital. We work closely with our spinal cord service and paediatric services. And we have an outreach nursing team which helps to troubleshoot problems in the community and provide 24-hour-a-day support. If if we then look, trying to give you some idea about the areas that we're covering with these services. So in Australia, this is Victoria down the bottom. Here we are in Melbourne, my hometown of Hobart right down the bottom. People tend to forget about. And then shooting in, this is a picture of a map of where our patients live across Victoria. So they really are scattered across a wide distribution, and means we have to have a range of options for how we can be in contact with patients, troubleshoot problems quickly if needs be, on a 24-hour-a-day basis. We even care for some people interstate down in Hobart. These services have grown exponentially. So I haven't got the dates properly across the bottom on this slide down here, but essentially over about 20 years we've grown from a service caring for a couple of hundred people up to about 1,000 people across the state. So there certainly is a clinical need for these types of services. Just going to finish off by giving you a snapshot of outcomes for patients under these community services who have tracheostomies in place over the last couple of years. This was done by our team with about 60 patients that have been cared for in the community. The average survival for those patients was 52 months, but heavily influenced there by those that had treatment for cancer. So about 50% of those that died within the 2-year period died from head and neck cancer. A lot of the patients with neuromuscular disease in fact live for years and indeed decades with tracheostomies in, and often with ventilatory support as well. Almost all of those patients are discharged back into the community, so most of them do not need long-term care in a facility, with that only being provided for a minority of our client group. And none of the deaths were actually related to tracheostomy care. So I think what it shows is by development of that very good expertise in a broad team, that you can safely care for patients in the community with a very low rate of adverse events. I'm going to hand over now to Christy McMurray. Christy's a senior nurse on the Tracheostomy Review and Management Service and has worked in our acute hospital as well, and one of our very expert nurses in the service.
Thanks. Thank you, Mark. I'd like to now discuss about the tracheostomy program that commences in the hospital. So the main aim of our tracheostomy program and the discharge is that for the patient to leave hospital with the essential skills and provisions to be able to conduct their care safely and actually confidently in the community. The TRAMS and various tracheostomy programs have long established a very structured education and training program, and we started as early as possible. We can't go into it all right now, but all those resources are up available on the website. A unique aspect about our services is that the same team follows the patient right through from insertion through to the community. And this sort of affords a really high level of confidence between the patient carer and also the clinician. So over approximately a 2-week period, a member of the tracheostomy team meets with the patient and their carers on a daily basis. We identify challenges, barriers. We also meet to identify some goals for discharge as well. And we work through those regularly. So the care team is preferably a minimum of 2 persons. We agree at the outset who the available carers are and who will actually be the primary support person for the patient, but also for the carer, because it's important for that to have that as a backup as well. The actual training program is multimodal. So we use things such as the online e-learning packages. We have videos, theory, we go through written instruction in the discharge manual, and we also do simulation and practice, lots of it. So the patient and the carer then learn about all the tracheostomy care needs, and they practice that while they're an inpatient. And we use the other staff on the wards as well. We couldn't do it without them. They continue that on and learn all those aspects. They learn about emergency management and how to troubleshoot any issues that they may have when they go home. Ultimately, even though the program is 2 weeks and we are getting faster at that, they still don't go home until they are confident and comfortable to be able to manage their tracheostomy. So when it comes to the actual program and who delivers the education, it really is a multidisciplinary effort. The key element to it is that we also work with all the clinicians and use their specialist skills, but also that we work with the patient. The knowledge that each therapist has from the acute admission is really critical, background information that assists us in discharge for follow-up appointments. So for instance, the speech pathologist, they may pick up a slight change in the vocal quality, which would be suspicious of a disease progression. Likewise, the physiotherapist that knew the patient as the acute admission but notices an increase in sputum load might think that there would be an underlying infection that we could treat. So all the clinicians, it's their responsibility to work together to create that program that suits the patient's lifestyle, their care requirements, but also their psychosocial needs. It'd be great for us to be able to say that all patients are the same, that we need force, lots of suction a day, heated humidification and once daily stoma care. That's not the case. Each patient is really unique, and so we tailor the program to their individual needs, and it's our responsibility to really try and understand what it is that they need. So one of our community patients here is Gareth Stevenson with his wife. He was asked what was one of the most important aspects of his tracheostomy training program, and he said it was just simply involving him in his care and education. It gave him great confidence and helped him to progress. I think we must never underestimate the importance of partnering with our patients and learning from them. This year we held our very first tracheostomy patient and family meeting. It was really great. So past and present patients came and they shared their stories. We got to learn from them and also how to do things better. When we think about tracheostomy, when we say we're tailoring the program, we need to also think about, obviously, the tracheostomy tube and the selection, and we get a heap of questions about what's the right one. As you can see here, this is one of our education boxes that has so many different tracheostomy tubes. It's quite difficult for anyone to try and work out what's the right one. Sorry, I've just got my notes. When we're finding it, the tracheostomy tube itself in the acute setting is not necessarily as critical as it is for the long term. We need to get that right. So I won't go into all the actual tracheostomy tubes, but Linda Morris has a really good textbook that actually talks about the majority of these tubes that you can see here, and she's one of the GTC members as well. Obviously factors such as right length, the cuff seal, the outer diameter, all play an important aspect to accommodate the anatomical and functional requirements. But we need to consider how the tube can be used to improve the improve care in the community environment. For instance, we had a question has been sent in about what to do in a patient with high secretion load, and what to do in the community. We would actually send a patient home in this situation with one with an above cuff line, such as a Portex suctionate. Using one of these tubes, we can use a 10 ml syringe to withdraw the secretions from above that cuff. That negates the need to do more frequent cuff deflations and ultimately increases the dignity of the patient. And that thing can be done by a novice carer. Sometimes though, and there's many different tubes and you can do a custom tube, but sometimes we really need to be creative. You can see that in this next slide, this is one of our patients that had an advanced oropharyngeal cancer, and it was inoperable, and his main goal of care was to go home on his farm where he was able to work independently. So initially we put in a Portex bivota tight to shaft. It was a fantastic tube. It conformed really nicely to his anatomy and was really flexible. The silicone shaft was great, and also the hub. But then what happened after a little while as his disease progressed and his kyphosis progressed is that his chin now became an obstruction of the tube here in the hub. So unfortunately with that, it was then embedding into his skin here in his stoma. So in theatre, we took the tube out, and what we did was we actually used a Bivona Hyperflex adjustable flange, which you can see here. we were able to put the tube in and then drag half the tube to the side of his neck. And after doing that, he was actually able to live another 12 months working his farm. So it was a really good way for him to live his life. I'm now going to hand over to my colleague Gavin Fay, who's one of the other. Oh, sorry, I'm forgetting. Sorry, I'm now going to hand over to Carolyn Chow.
Thanks, Christy. So this is the first of our polling questions, and we're interested to learn about the humidification practices for community patients in other centres. So if you look to the right of your screen in the little box, you should be able to use your mouse to click on the different options and answer the question. Do you or your centre use any of the following practices? So we're going to pause for a moment to give you a chance to answer this question, and results of all the polling questions will be summed up at the end of the presentation. So I can see some excellent answers coming in. Okay, so it looks like most people have answered that question. Thank you. We'll sum it up at the end. Okay, so as Christy mentioned, although our community tracheostomy program do have a standardised education program and standardised equipment, within those programs we are able to customise some of those options to tailor to the patient's needs. So we've just seen the polling question about humidification, and this can often be downgraded as the patient moves from an acute phase in hospital to being ready to transition to the community. And the majority of our patients still use heated humidification at night, but to enable more portability and better mobility during the day, they might switch to a heat moisture exchange device. Thank you. For those who are troubled by more tenacious secretions, we might also consider some other adjunctive measures, such as saline nebulizers or lavaging. But again, these need to be tailored to the patient's needs, and the frequency of them will be individually selected. Going hand in hand with humidification is secretion management, which for most patients would include training either the patient and or their carers in tracheal suctioning. Here's a picture of one of our patients performing self-suctioning. For those patients who have an adequate cough, though, they might feel it's more comfortable to actually cough independently to an inner cannula and then be able to change the inner cannula rather than suctioning so frequently. On the other end of the spectrum, there are also those who have significant difficulty with secretion clearance, such as those with spinal cord injury or neuromuscular disease. And while certainly it isn't routine practice, for those patients who do need it, we have utilised devices such as mechanical inexflation devices, or set programs on ventilators to deliver a hyperinflation physiotherapy program to help them clear the secretions. But again, these need to be tailored to the individual. And finally, but perhaps probably one of the most important considerations, is enabling communication for our patients. And our speech pathology colleagues work hard to give our patients options. And just like us, patients often use a variety of different methods to communicate. For our spontaneously breathing patients, this would often include either finger occlusion or using a one-way valve. And for our invasively ventilated patients, this may include valve in line or ventilator-adjusted leak speech. And of course, there are the other options such as eye gaze, communication boards, electronic devices, and apps. So now I'd like to introduce clinical nurse consultant Gavin Fay, who works on both of our services, who's going to talk about managing our patients beyond the hospital.
Thanks very much, Caroline, and hi everyone. I'm here to talk a little bit about beyond the hospital, which is great because whilst hospitals are terrific places to have around, they're nice to leave behind you as well. So I guess it's pertinent to discuss where the individual with the tracheostomy will be living, and we generally accept the home environment as the preferable option because of some of the advantages in living in the home over residential care, such as improved quality of life, access and integration to the community, better social interaction, and as well as some cost-saving benefits. I should also mention here that in Australia we don't necessarily have access to long-term acute care hospitals and skilled nursing facilities, which may be available in other parts of the world. So we really rely on residential care and training people up in those facilities. When we're discharging someone into the community with a tracheostomy, it's really important to engage community services as well. Some of those will be short-term, such as community nursing services. Here in Victoria, we have Hospital and Home and the Royal District Nursing Service, who can visit the patient on a daily basis for a short period of time just to assist that transition back to the community. And granted, some of those clinicians won't have a lot of experience with tracheostomy management, and so this is why we would support them, as well as provide generally a checklist to guide them through the things they should be checking when they visit that patient. And then that forms a document they can send back to us, and we can follow up as necessary. The local doctor is obviously really important for anyone being discharged from hospital, particularly complex patients. Sometimes we'll utilise a local hospital, particularly for those patients that will be going back to a rural area, and in some cases, in fact, we'll transfer them back to that local hospital and assist the discharge from there. And the advantage, of course, in that is that that local hospital then has a history of that patient that will be moving back into their community. Central people like case managers and carer and agency leads are really important too. They can field issues with patients and refer them on to the appropriate service, including ours. Now we've got another polling question we'd like you to get involved with. Where do your community patients have their tracheostomy tubes changed? So once again, we'll just give you a little bit of time. You should have something pop up there. Okay, I might move on. Christy spoke a little bit about ongoing training. And obviously training is really important within the hospital, but also on an ongoing basis. Can't see my slides at the moment, that's okay. So the ongoing training that will be needed in the community is sometimes dictated by the complexity of the patient, but also where they'll be living. We find in the home there tends to be a smaller core group of stable carers, including family, and so that ongoing training might be less frequent, or it might be required less frequently to, say, a residential care facility where there's a large number of staff that might be turning over, and our support might be more frequent. Where we change and how we change the tracheostomy tube will depend sometimes on the risk of the patient and their tube change. And so we have a policy here where we always change the tube within the hospital prior to any service undertaking the change outside of the hospital. Are they 24-hour dependent? Is their tube change itself quite difficult? Where do they live? Once again, if they're moving back into a rural area, do we need to train someone locally, or do we need to refer to a service such as ENT locally to undertake those changes? And of course, we have many options in terms of where we change. Outpatients, day admission and home are obviously places that we can change the tube, and many patients have their tubes changed within the community. Now, our support doesn't stop at tracheostomy tube changes and training. We obviously need to be on hand for our patients in the community to troubleshoot issues as they eventuate, and these might be related to the tracheostomy, or there might be something else completely. So we do a lot of this over the phone, and we can obviously refer them into clinic for a face-to-face review, or we can attend home visits if that's necessary in between their tracheostomy tube changes. Another platform that's really taken over in the last few years is teleconferencing, and Austin Health are lucky enough to have a couple of services who are piloting a state government platform called Telehealth, which has been really successful so far. It's important to talk about equipment management within the community here because we do have the luxury of supplying all required equipment to our clients within the community. And this ensures that the equipment is functional and working correctly, but it also ensures that they're using clean equipment, and so it's a big safety piece. We have a hospital database alert system here at the Austin so that if our patients represent to this institution, there'll be a system alert on the database that has the capacity to send alerts and emails to the treating team to let them know they're in emergency. Rather than me talking anymore, we would like to show you a short film, a 5-minute film of a couple of our community clients, and we'll hear from them. Hayley's going to take over this, and hopefully it works. We did have some tech problems earlier, but we'll see how we go. So bear with us.